Well, what I'm going to start doing is because some of the modules are like you need to respond to other people's comments and have interactions and engagements. One of the things I probably failed to mention in our last um, experience is uh, in order to get the best out of your experience, I would encourage you to engage early in the modules, or at least in the time frame for which they're prescribed on the syllabus. And that's when you're going to get the most feedback, the most comments from people. If you're going on there like the day before everything is due and you're putting a comment, you're probably not going to get comments or feedback back from other students. And so that's a really important part of the learning experience. So I encourage you to get in there and try and do much of that early. Um, the other thing that I should mention just briefly is a small apology. I'm going to make a small change already to our syllabus, to sort of our structure. Um, I was gently reminded that I double booked myself for Tuesday and have an issue there. So what I'm going to do is I'm going to record a lecture and post it for Tuesday that you can go in and you can watch. And I'm going to get on there and talk about person-centered and probably a bit of Gestalt at that point. Depending on where we get today, it may include some existentialism, but I'll record kind of a 45-minute, hour-long lecture for that day. And so we won't meet live. I will also make an announcement about that on Canvas so everybody's aware. So we won't be able to do that Tuesday. And we'll just push to the next time when will meet live according to the syllabi. So in the meantime, if you need anything, let me know, reach out, email, Canvas messages. I think that's all been working so far. So um, let's jump in for today. I think we'll probably go till probably about 10 o'clock or so and cover some material, talk about some things in material, and then kind of open it up for some question and answer and get some of your experience and uh, see kind of where you're at with the material. So we'll do that. So our focus for today is many of the things that you started in your early modules, law and ethics, as well as Freudian psychoanalysis. Adler we'll get into, and I'm going to try and give you some pieces that are not necessarily a part of your normative slides or part of the experience that you have so far. So I think it's really important when we first start talking about counseling or anything counseling related is to talk about law and ethics because they can be like our best friend and they can help us a ton. There are three main concepts to laws and ethics that are protective, that protect us as counselors and protect us from three specific groups. Having ethical codes and specific ethic codes protect us from three groups. First is they protect us from the government. Uh, what do I mean by that? Well, laws are created, all the laws according to what we do in terms of practice are created for the state of California, are created by individuals in Sacramento. Now, most of those individuals have very little familiarity with our practice and what we do as counselors. And so often what you'll find is psychology groups and counseling groups, uh, medical groups like AMA, APA, ACA, CAMPT. They have lobbying bodies, which just means they send people to Congress to educate individuals before they're passing laws, especially laws pertaining to our profession. Some years ago, I was in Texas, and APA was lobbying the state of Texas to get our marriage and family therapy license in a different classification. They argued and lobbied to get it put into a classification that fit more along the lines of like food handlers in the state of Texas or sanitation workers, janitorial services in terms of licensing. Because what that would do is it would take away a therapist's ability to really diagnose. And diagnosis is where really insurance money pays out. So the main reason why we use the DSM for social work or marriage family therapy or for any type of psychology is medical reimbursement, is insurance reimbursement. So we have sort of governmental eyes that are sort of watching our practices and can modify and change things within the scope of what we can and can't do. And they prescribe largely what we can and can't do. So things like psychologists really aren't within the scope of practice within the state of California, really don't do couples work, where marriage and family therapists, they do couples work. In recent years, there's been sort of a shift, but even social workers were not really licensed to do or allowed to do couples work. And LPCC was kind of the thing. We talked about some of those acronyms last time. So that's good. But if you look at sort of the jurisdiction and what the law tells us what we can and can't do, it stays very broad and generic. And then we have these business and professional codes, or B&P codes, legally that set the groundwork or the framework for how we can lose our license. Under what conditions can the state take away our license? And they can do it for lots of different reasons. Unprofessional behavior tends to be the predominant way that they do that. The vast majority of how that comes about, like why most licensed counselors lose their license, is public intoxication or drinking and driving. That's number one. There can be lots of other various forms, whether it's child abuse or other run-ins with the law and legal issues, but the vast majority of the time it's has to do with alcohol or drugs that are consumed, and then there's law enforcement brought in for whatever different reasons. So that's where it gets really fascinating. So I have like psychiatrists who we have a psychiatrist in our department that teaches one of our psychopharmacology classes, and he says he does not drink in public, period. He will not drink alcohol. Like at a restaurant, he'll just drink water or soda water or something, and then he'll go home and he'll consume alcohol at home. But he will never run the risk of either drinking publicly, in part, he says, because he doesn't want his like clientele to like see him doing that, but he never wants to run the risk of getting in a car with any sort of alcohol in his system and getting pulled over for any reason, because he could lose his license like that. So that's the vast majority of reasons, right? So what happens is each individual profession, the American Counseling Association, American Psychology Association, social work associations, California Association of Marriage Family Therapy, the American Association of Marriage Family Therapy, all these individual associations that represent sort of professions come up with ethical guidelines. And those ethical guidelines are much more stringent or much more strict in many cases than what we're going to get from legal entities. Like the state is not going to tell us all the specifics of what we can and can't do, which is good. We don't want the state to do that. We want our own professionals to tell us what safeguards we need in place. And so they're a little bit tighter. And typically, if we abide by our ethical guidelines within any counseling profession, then you're going to stay out of legal trouble. That's just the general rule of how that works. And so we do that. We love ethical guidelines because they protect us from the state for that very reason, right? If we keep our ethical guidelines, we don't have to worry about what the state's going to do. We don't have to worry about, losing our license if we're abiding by the things within our ethical standards, right? They also protect us from the general public. They protect us from the general public in that when we are abiding by our ethical standards, if a client wants to come after us or sue us for something, whether it is a civil lawsuit or something of that nature, professional lawsuit because of malpractice or whatever, we usually have insurance. And our malpractice insurance will cover us in the events that we are abiding by like our ethical standards, right? And so usually those ethical standards will protect us legally because we were doing the things that we needed to do. Probably one of the most famous cases was the Tarasoff case. And this was set the groundwork and the framework for all we do in terms of homicidality in our ethical standards and practice. There was a student in a university in California. There's a lot of California influence, I'll just say that, in our ethical standards, even across the entire United States. And there was a young man who was infatuated with a girl, and she did not necessarily want to be with him, and engaged in stalking behavior and lots of other things. And he'd been seeing a psychologist on the campus, and ended up telling the psychologist that he was going to do things. The psychologist reported it to campus police. Campus police went and investigated, but they didn't really find out or see anything. Turns out he ends up killing the girl. And the parents came after the psychologist and said, "You should have done more." And from the Tarasoff case, it was determined that yes, therapists need to do more in terms of discharging their responsibility at that point. And part of that responsibility and what changed in our profession is now we have to notify the intended victim. Any intended victim, we would need to notify them. And so he would have had to do, the psychologist, to discharge his responsibilities, would have had to reach out to family, would have had to reach out to roommates, would have had to reach out to the girl herself to notify her that she was in danger from his client, which is him breaching confidentiality in order to do so, but is a legal mandate to do. So we can still, be sued and things like that, but largely our ethical standards and our legal standards really protect us in the case of those things. The other entity that our ethical standards protect us from is fellow practitioners. Yay. I think I'm painting a pretty scary picture. Like everybody's out to get counselors and everybody's out to get, therapists and that, but that's not the case. But there are guidelines within our ethical standards that tell us how we need to comport ourselves, how we need to interact one with another. Maybe a key portion of that is within our ethical guidelines, you cannot have sex or have a sexual relationship with clients. You just should not do that for any reasons, right? In the other 49 states, they have different sets of ethical standards within like marriage and family therapy practices. And they say never, ever, ever, ever. If once someone has been a client of yours, you should never have a sexual relationship with that individual. Like, doesn't matter if it's 15 years down the road and they're no longer your client, like should never happen. In the state of California, they say 2 years. So 2 years post treatment is when you can have a sexual relationship with your clients. And there's some smiles. It's good. I'm sure even people without their screens on are going, wait, what, how is that? But even within those guidelines, just if we delve into the weeds there a little bit, right? Even within those guidelines, like you would have to demonstrate and show that you terminated therapy. There'd been no contact within those 2 years. It's not like you were like grooming or courting them during those 2 years. And then you hit that 2 year mark and it's like, boom, honeymoon, night or wedding night sort of concept. And now we can have sexual relationships. Like you can't be doing any of that. It has to be much more of a like organic type of concept where something happens 2, 3, at least 2 years later, there's some interaction or resurgence and bada bing, bada boom, now you're engaged in a sexual relationship sort of idea. But within that ethical standard, we as clinicians, so if I'm in my office and I have a client that comes in and the client tells me of a previous therapist that was having a sexual relationship with them, I cannot disclose that information. According to our ethical standards, I cannot report that therapist. According to my ethical standards, I have to have a pamphlet on hand that says no psychotherapy should include sex. And I hand that pamphlet over to my client, and then I educate them and teach them about their rights and the opportunity for them to report that. But that is not something that I do, which can be really important in terms of counseling practice. One, because I'm trying to say this really in a light way. I don't know that some people would lie. I don't necessarily know that, but I do know what often happens is like when you see clients from other counselors, you'll say, "Hey, how'd it go?" And they'll be like, "Oh, I hated this, and they did this, and they did this, and this, and this." And in many cases, as counselors, we can be like, "Whoa, why would they ever do that? That's crazy," you know? Or in some cases, we could look and go, "Oh, well, that's the context for things, right?" If I get a client that comes in and goes, "I really hated my last therapist. It's so weird. They would like talk me into stuff, and then they would like do this clicking thing with their fingers, and and if I'm uneducated about what they're doing, right, then I could be like, wow, why would they be clicking fingers and doing this and having you look different ways and then talk about things uh and I'd be like, that's really silly, and they shouldn't be practicing, or that's unethical, or whatever it may be, right? But it could be that they were practicing EMDR, right? Or this could be a therapist who's doing EMDR. It's not then my place to say whether they were doing EMDR right or wrong or anything like that. And so ethical standards protect us as clinicians from other clinicians and help us protect ourselves from, or give us guidelines for, what our relationship with other clinicians should really look like. So those are the three main things. This is why ethical standards, legal standards are important. They protect us from the state, they protect us from clients, and they protect us from our fellow practitioners. And those are three really, really core concepts when it comes to ethical standards. Other key pieces that I'll mention just briefly, you probably read about confidentiality and learned about confidentiality a little bit. In the state of California, we are obligated, required by law to maintain confidentiality, except in the case of, anybody know? Suicidality, right? Child and elderly abuse, and homicidality. Those are the three conditions. Other states may have other things over years. Like I don't know if they've changed or not, but in some other states that I've been in, they've had like the willing spread of communicable diseases without disclosure. Like that was a mandated report for therapists. One of the ones that's really interesting to most students is domestic violence is not a mandated report for counselors and therapists. It is for medical professionals. Like if you show up to a hospital, if anybody shows up to a hospital and they've got like bruising or breaks or something like that that seems skeptical or suspicious, then a medical professional has to make a report to authorities, to like police officers. But we as clinicians, we are not mandated to report in terms of domestic violence. Jack, you have a question? Yes, question? Jack? No? Okay. Oh, my mic is not working. I'm glad you put it in the chat. Um, Sexual harassment or sexual abuse. Those all fall under the umbrella of domestic violence. But the age is the important variable. So if we're talking about any of those behaviors related to children or minors, then yes, that would be some form of child abuse. And there's various concepts under the umbrella term of child abuse. physical, sexual, emotional is a super gray area in the state of California. And so that's often not one that is really reportable. But with adults, adult to adult, domestic violence is not one, which is in some ways is like really good for our profession. Because if we had to report all domestic violence, usually what ends up happening is when someone comes in and within the first couple sessions and they do something and we have to mandate, we're mandated reporters, we have to report it. A lot of times they turn away from therapy. So domestic violence is one where in order to really make ground and help people in that area, we do a lot of advocacy work for them and help strengthen them. But in many cases, we could make things worse for them by just forcing them to report and forcing them to do things. So it's hard. I would tell you domestic violence work is some of the hardest work I've done clinically, to work with individuals who have been abused on either side. And that's male or female. It doesn't matter. It goes both ways in terms of like anybody who experiences domestic violence. There's so much context and so many reasons as to why they really don't do much regarding that. So that's kind of legal and ethical. You didn't wake up this morning going, "Oh, I really wanted to learn more about legal and ethical concepts in counseling." But those are probably the main highlights in terms of concepts. There's several others, but I'll let the slides and that handle it for you. Let me see if you have any questions, or you can do like Jack and raise your hand at any point if you have any questions. Let me pause for 10 seconds and see if anybody has any questions.
In the lecture slides, there were some like ethical dilemmas of like examples of possible things. I was wondering if you could go through those and like maybe let us know like the answer or the thought process on those. I was trying to figure it out on my own and I was like, I don't know if I'm right.
Okay. So you're specifically talking about like bread? Is that what you're talking about?
I don't remember their names, but I think there were like 2 or 3 like ethical dilemma examples that I was like working through in my head, but would like clarification on. Any of the
Okay.
3 would be like there was one about a guy that went to church with someone and it was maybe a like dual relationship, but I wasn't sure if it actually was.
Sure, we can go to Jim. So here's the one from Jim. This is a dual relationship example. So Jim and LMFT and his family have been attending the Well Church for several years now. Just recently he notices that one of his clients sitting a few rows back. At a certain point, his client Stacy comes up to Jim and says hello. Jim now feels a little uncomfortable that one of his clients is attending church with him and that they will probably run into each other frequently. What should Jim do? Now, the concept of dual relationships is when we share space in more than one relationship, right? So by definition, Jim now has a dual relationship with Stacy because they are fellow parishioners at a church, right? If I go to the same gym as, and not like GYM, not JIM, sorry to use both names. But if I go to gym with clients, right? We now have a dual relationship because I see them in a different context than just in terms of counseling. Having dual relationships is not, by definition, unethical. It just is a concept. But we are instructed to not have unethical dual relationships. And what that means is we can't have relationships that would compromise ethically. Our guidelines are to not have relationships that would compromise what our professional judgment or that would put undue influence on our clients or patients. And so when we look at Jim's scenario here, right, I put in here 4 options. Okay. we can look at Jim's experience and say, okay, he has a dual relationship. Is this an unethical dual relationship? And we would probably say, not necessarily. Unless Jim felt like it was influencing his clinical decision making, or if he felt like it was putting some undue influence on Stacy. So let's read our 4 options that I gave you, right? So should he keep on attending the same church because they are just fellow parishioners and it's not a dual relationship? Should he be? The Well has several campuses. He should just attend another church, no biggie. C, this is clearly an unethical dual relationship, and Jim should provide a referral for Stacy to be seen by another therapist because she's not going to go to another church because he's not going to go to another church. Or D, Jim should have a discussion with Stacy during their next session about the potential issues with attending the same church and the possibilities of an unethical dual relationship occurring. So the best answer, so it's not going to be A, right? Because he's not speaking or addressing the issue of a dual relationship. He should not do B because Stacy's going to notice that he's not there anymore and will ask him about it, and it's not going to help the situation. C is incorrect because it is not clearly an unethical dual relationship. And so typically when it comes to dual relationships, we want to have an open discussion with our clients to ensure that they don't morph into something else. In this case, right, if Jim had been doing therapy and Stacy had been seeing him, now what we might get if they never talk about it is Stacy may be going, okay, now I'm going to like include concepts of my spiritual beliefs and religiosity, and I'm going to like ask Jim for his feedback on that, or get some consultation about spiritual matters that I'm having because he attends the same church that I do, or something of that nature. And so therapy now becomes less of therapy and maybe more of like biblical studies, or like a pastoral counseling type of concept, which may not really be what Jim is doing. And so Jim's got to safeguard himself from conflating the two in terms of those relationships. Now there are different religions and different churches where you engage in volunteer responsibilities. And let's say that we heighten this experience a little bit more, and Jim is now in charge of the youth group, right? And I apologize if I'm misspeaking. I don't attend the Well or know the Well, but let's say the Well has a youth group, right? And he's now in charge of the youth group. Well, Stacy has an adolescent who is in the youth group. And so now Jim is in charge of, or has responsibility for, or engages with Stacy's son. Should Jim take that responsibility as a youth group leader or instructor, knowing that that would probably create an unethical dual relationship? And the answer is he should probably not take that responsibility. He should consider something else. And so his options are to refer Stacy out or not take it. So, in which is always an interest. I've personally had something similar to that happen where I was seeing someone, had no other association with them at the time, and then they started attending a church where I attended, and they walk in, and I was like, oh, okay. So then we had a side conversation. I said, hey, everything's still confidential. I was no longer seeing them, but I said, hey, your information is confidential. I'm not going to share it with anybody. Like, this isn't going to come out in any other context, and just reassured them of confidentiality. And then within like 30 minutes, they promptly walked up to my wife and said, oh, your husband, I used to see your husband in therapy, and he was my therapist, and he was so great. And what, talking about all this stuff. And I'm like, oh, okay, you're right. I mean, that's what they can do. But I don't disclose any of that information. So that's why we sort of have sort of ethical guidelines for all that. That help a little bit, Paige, with one of those?
Yeah, it was helpful just to hear the thought process of walking through. I thought it was either A or D. It makes sense that you would have to like get it out in the open and discuss it. Thank you.
Yes, yes, good. And then the other ones, I mean, the other sort of vignettes are just to get you thinking about things. The really interesting part about ethics is ethics isn't about memorizing a bunch of codes and being able to regurgitate and have clear guidelines. Uh, Ethical dilemmas within our practice usually mean that there's conflicting concepts. And so therapists are really encouraged to consider that, like to consider that you're not going to make the right decision all the time. There's no such thing as it is black and white right decision. It's more of you're going to have to do the best that you can and try and make the best ethical decision possible. And not everything's going to be just cut and dry. Let's see. Jordan says, I had a really hard time navigating the Michelle one. Um, Michelle, 2 times a week. So an LMFT has been working with Michelle, age 32 times a week on issues of depression. Michelle was diagnosed with a recurrent major depression. At the onset of treatment, Michelle reported suicidal ideations and one suicidal attempt or suicide attempt. Over the last 3 years, Michelle's symptoms have significantly improved. However, 4 weeks ago, Michelle lost her job and has begun discussing her lack of luster for life. Although Michelle stated she didn't have a suicide plan, she admitted that she thinks about ending it all. Every few days, also starting 4 weeks ago, Michelle's checks had begun to bounce because Michelle is seen twice a week. The LMFT is losing hundreds of dollars and having trouble making the rent payment. LMFT, the LMFT had decided to terminate Michelle due to non-payment. When the LMFT told Michelle, Michelle indicated that if she couldn't see the LMFT, she would kill herself. The LMFT agreed to see Michelle 2 more times for free, but at the end of the second session, Michelle again stated that if she couldn't continue counseling, she would end it all tonight. The LMFT suggested other referrals, but Michelle refused to take them. The LMFT evaluated Michelle for suicidal ideations, but Michelle would not answer specifically. Michelle stated, I'm afraid of not seeing you anymore. You're abandoning me. The LMFT decided that based on her financial situation, she would have to terminate Michelle and told her so. Michelle ran out of the office crying. The LMFT attempted to contact Michelle over the next few days with no response because the LMFT did not have any emergency contact information for Michelle. The LMFT called the police to suggest a wellness check. The LMFT remains confident in her decision to terminate Michelle. What is an ethical dilemma? Good. I'm glad that one is so Jordan, tell me about what you're having a hard time navigating with that.
The like what to do differently bit of it at the end is like what should the LMFT done differently?
Hmm.
Because I was thinking, well, that's kind of it's like to me, seeing all that, I was like, given how it progressed, I'm like, it made sense to have gone the route that the LMFT does. But I'm like, I don't really know how differently you would handle something like that, given the ethical bounds that you have and don't have.
Yeah, it's good. It's a good question. What could they have done differently? Hopefully, everybody had a chance to read that one over, but uh, it's mostly a question, not insinuating that the LMFT did something wrong. That's not the goal of that question. But for each one of you, it's going to look a little bit different when you're in that sort of situation. Um, I think part of the justification for the LMFT terminating therapy is that they they are dealing with the financial constraints of it, right? And you are not ethically obligated to continue to see somebody when they cannot pay for services. You don't have to do that. And in many cases, and the reason why I put the whole rent concept in there is because that is your livelihood. And that can influence your clinical judgment towards someone. Like, I mean, if all is well, like when everybody's winning, like everybody gets along sort of concept. But when things are rough and you're not really collecting money from anybody or from a specific individual, and they're occupying a lot of your time, like twice a week, and you're not being able to make ends meet, that can really impede and impact your clinical judgment. You can have sort of judgments towards them. So one of the things that I would suggest for that clinician specifically is that they counsel with somebody else. I would have encouraged them to make notes or to document that they had met with another professional about the decisions that they were making, and to document that so that they understand that they're doing it within the concepts of standard practice within our field. The other thing is that the decision, when they're making the right decision, needs to be a little bit more definitive. So allowing them to continue to see, right? And saying, clients saying, I'm going to kill myself if I can't be here, can be a bit manipulative. And I don't mean like ill-intentioned, but it is they're trying to manage the decision-making, the ethical decision-making of the clinician. And clients do that all the time. All the time. I've had clients who are like, hey, can I pay you, how much do you actually make from this session, right? Like I pay X amount to the clinic, but how much do they pay you? Like, how about I pay you more and that we see each other privately, right? And I'm like, oh yeah, that's so nice of you. They're looking to not pay the full fee and pay a less fee, but that it's all direct money to me. But that's highly unethical. But that's, and they're not coming from a bad place. They're just going, hey, yeah, finances can be tight sometimes. So people try and do that all the time. And it's good to be definitive in those moments of what is okay and what's not okay. So I love you wrestling with it, Jordan. I hope some of those other ethical concepts you all wrestle with a bit and have some challenges with, because that's the nature of what we do constantly within our field. Is you should be wrestling with it. And some of the best clinicians I know, wrestle with things constantly. And you should. The other thing that I'd say about counseling is never practice on an island. So never practice alone or in isolation. Always have people that you can talk to, chat with about dilemmas that lie before you. So those are all great questions. Let me switch gears just a little bit in our last about 15 minutes. So let's jump into theory just a little bit to understand. And I want to give sort of a history of really the theories that we're talking about here and really where they come from. Up until now, as we enter into a world of Freud, up until that point, the vast majority of what had been done functioned under we'll call it the medical model, which is highly scientific and highly professional behavior. And what I mean by professional behavior is a clinician was separated, like a physician was separated from their patient. It was, I know what to do. I'm going to tell you what to do. You do what I tell you what to do, because I have all the knowledge and information and you do not. And so I'm going to tell you how to do this and you're going to do it, right? We don't necessarily live in those days anymore. Many of you probably stay well informed as much as you can, without actually going to medical school. But we tend to look stuff up online. We ask Google and Siri and Alexa and all kinds of others. We consult with friends and we talk to people just in general. And so we try and be very informed consumers about what's going on. But in many respects, we still go into physicians and they tell us to do something and we're like, oh, okay, Okay, we'll do it, right? Like that medical model still really exists. At the time of Freud, that was really the case. And most of what was seen and experimented or determined was like we'd separate people out and say, medically you've got stuff going on, and then mentally we're just going to put you in sort of a excuse the language, but like a nut house. We're going to put you in a psychiatric ward. We're going to put you in and restrain you because you're a detriment to society, right? And Freud actually started to go, let's look at this a little bit different. And he was very, I'm not saying politically, but the actual term of liberal, right? He was very liberal about his understanding of mental health and wanted to be able to study and understand mental health in a different way. And so he began to look at patients not as like permanently damaged or destroyed, but like what really is driving a lot of this stuff. Like, where is this coming from? What's happening with this? And let's look at this in a different way than just, hey, let's lock them up, right? And so Freud began to look at people in a quite revolutionary way for his time. But many of the things we see and experience with Freud still exist. In fact, you can go watch any kind of movie. The vast majority of early movies that portray therapy really are probably more Freudian psychoanalysis, where it's you got a big desk and then the patients on one side and the therapists or the clinicians on the other side, and there's a big desk in between, and it's like I know what I'm doing, and I know I'm the professional, and you don't, and so I'm gonna tell you what's up. And so they do a ton of analysis. They ask a lot of questions, a lot of probing questions, and it's just there's not a ton of warmth and validation and stuff that probably when you think about the idea of therapy now or counseling now, you're like, oh, it's got to be warm and it's got to be inviting and it's got to be you figuring out your own narrative and you knowing yourself more. That's not really what therapy was at the time because it was coming from sort of a medical model. So many people don't like old school Freud, but we delve into Freud probably way more than you think, right? Like how often do we blame parents or do we blame when we're faced with problems? Do we just inherently turn backwards into history and blame something that happened in our past, right? Freud's view of human existence was largely that we are deterministic beings. And that mixed with biological desires for sex makes sort of a complicated experience that when we don't get those basic necessities, specifically biological, sexual necessities met, then we're met with a lot of complications in terms of our development and our growth. And so he was really deterministic and would say most of what we do is in response to those deterministic things when they don't line up with social norms or social constructs within differing contexts, right? When it's seen as socially unacceptable for me to express sex or get sex or sexual desire met in certain ways, then what I do is I suppress that. And now that suppression of that desire or that instinctual part of me now comes out in other forms. And so Freud had, right, concepts for that, like a number of concepts for those sort of unconscious things that were tucked away. And he called these ego defense mechanisms, right? And that we had those as a way to protect us from many of those repressed sort of feelings, right? So you've ever heard of the term repressed anger, right? Someone's like, oh, that's some repressed anger. Okay, it's not really about anger. Freud would say it's about that biological deterministic side of us. Now, in years since, we've, many people pushed away from that. In fact, Carl Jung and Alfred Adler, who were proteges of Freud, we're like, that's a little too deterministic. Like, we're also human beings and we get choices. Like, we make choices that are not just based upon like sexual drives and and desires that we have, right? It's not just a biology and we're subject to that biology. We have lots of other contexts. And so Alfred Adler comes along and goes, oh, well, let's look at family as a context for development. And maybe birth order, sibling order, which was totally revolutionary idea at the time, maybe your sibling order has an influence on you, right? And you could probably see this, and there's a reflective activity on Canvas for you to do as well. But you could probably see this in that you being, if you have siblings, you are a little different in certain areas than your other siblings, right? If you're an oldest, you're probably different than the youngest, right? And youngest gets labeled a certain way, oldest gets labeled a certain way. If you're somewhere in the middle, then you're probably perfect. I'm just kidding. I guess I'm a middle child, but you get lost, right? But there's also other really fascinating concepts. In recent years, in the past decade or so, they've done this really cool research where they find out that the majority of people that go into helping professions, counseling professions, teaching professions, are younger siblings. And they've connected it to younger siblings get more time to watch and observe and listen and see. And so I watched all my older siblings get in trouble. And so I knew what not to do, right? I also saw them go through lots of things. And so emotionally, I was much more attuned to certain things than they were. I could probably tell you more of my brother's life, who's 2 years older than me. I could tell you more about his life than he could tell you about his life, which is kind of an interesting concept. But birth order has a huge influence on us and a huge impact on how we develop and how we grow. And there are subsequent theories that have grown out of that since that time. But Alfred Adler was kind of the first one to discover that and to also introduce the idea that we have choice or more choices in the matter of our development than what we really think. So that's where we kind of then deviate, and choice becomes more of a part of even modern day theory and how things work for us now. Let's see, I'm getting a warning from my computer that my battery is really low. Oh, that's not good. Give me 2 seconds. I'm going to get to my outlet. Sorry about that. I didn't realize my battery was dying so fast. So, um, in general, right? Adler, Jung, Freud, we're trying to understand phenomenology, which is why people act the way they do, and why we find certain behaviors existing in people. Choice, determinism. Then we shift into sort of existentialism. And existentialism was a total deviation from a lot of that. And I'm wrestling with how much I really want to get into existentialism today, because it's so much more than just the idea of why people act the way they do. Existentialism involves a philosophical note that is now not just why do we do what we do, but concepts of like existence. or for what purpose do we exist, or what is our overall value and worth in terms of existence. And their existentialism is not tied to any specific philosopher or theorist or clinician or practitioner. There are many existentialists who have impacted existentialism across time. But by and large, the view is we create meaning in our life by engagement in life. And so existentialism is this idea that we create value and meaning through engagement. But we run up against existential crises or existential angst, or what existentialism did was say, hey, anxiety is a normative part of life. Because anxiety is when you're faced with what is my purpose and what is my value? And how do I find meaning in the things that I'm faced with? And existentialism presents a lot of really cool variables, right? Cool dichotomous variables. Things like freedom and responsibilities are dichotomies. They go hand in hand. They exist, right? You can't have freedom without also having a sense of responsibility, right? If you try and have freedom without responsibility, then you're going to run up against existential crises all the time, right? My freedom to do whatever I want or make whatever choices I want does not also mean I don't have consequences. And so, doesn't preclude me from having consequences in my life. So I have to manage and balance the freedom of what I do with responsibility that I have to the very people that I have freedom for. So, for example, within the context of the United States, we have laws to which we give up our freedoms. We give up individual freedom in order to help other people. A small example of that is I pay money and I give up freedom, like I consent and give up my freedom to drive however fast I want to drive, whenever I want to drive, right? And I give that freedom and that power over to the government in order to create bodies of enforcement that then can come and issue me a citation, a warning, a ticket anytime that I am exceeding that. Because my responsibility is not to just do whatever I want, but my responsibility is also to the people around me. And if I drive the way I want and how I want, whenever I want, then I can put in danger those around me. And so freedom and responsibility go hand in hand. And they provide value and meaning for us. Once I function under that and engage in that way, then I find more value and meaning in my life. Is kind of existentialism. One of the Viktor Frankl is one of the big time existentialists. And Viktor Frankl's interesting. Has anybody ever heard Viktor Frankl? He wrote a book called A Man's Search for Meaning. And Viktor Frankl was in concentration camps in Germany. And he largely speaks, and most existentialists speak against big groupthink. They saw these things happen in Germany. You're singularly identified, and your individual freedom and making choices is subservient to a bigger identity. And so those identities then don't take responsibility for the individual decisions that they make, or they justify the individual decisions that they make, right? I am a Nazi, therefore I need to do this. I'm just taking orders. And Viktor Frankl, in a personal note, went, hey, I'm not just a concentration camp prisoner. And so I can find meaning and value and I can make choices within the context of my life, even when I am in a concentration camp, which I think is such a powerful concept for an existentialist to propose, to say, even in the midst of like really terrible things that happen, you still have a sense of freedom and you have a responsibility for that freedom. And for him, it was, my freedom is I can look at the day how I want to look at it. I don't have freedom to go outside these walls. I don't have freedom to eat whatever I want. I don't have freedom to do all these other things, but I have freedom to feel and choose the way that I want to feel about things. My children certainly don't like that concept, right? When they get in fights and arguments and they hit one another, and I go, "Why'd you hit him?" And then they go, deterministically, Freudian, if you will, they go, "Oh, I hit him because they hit me," right? And then I go, existentially, right? Well, you are not deterministic in that. You do not have to hit them because they hit you. You get to choose how you respond. And hitting them back is not the responsibility that you have or grants you the freedom that you want within that context. And they don't like that, right? Or even sometimes in the way we feel, we go, "Hey, they made me angry." Oh, my children don't like when I say they made you angry. Because you could feel anger, but no one makes you feel something, right? It's always you get a choice in terms of how you respond and how you engage with the things that you feel and you experience. It's not deterministic in that way. Because that's where existentialism becomes kind of cool and interesting and fascinating, because it's simultaneously an exploration of phenomenology. Why do we make the choices we do and act the way we do, as well as this philosophical, what really is our purpose in life, right? Why are we here? How do we find value? What's our meaning? What's our purpose? Sort of concept, which includes and involves different ways for us to sort of explore and understand ourselves, as well as how we navigate sort of the world around us. So that's kind of a nutshell of, here's some of those concepts that you've been exploring, hopefully a little bit different to the side of what you've been learning in your module work with those so far. But let me pause and see what questions you have about any of that content that we've discussed so far. I've overwhelmed everybody with the theory so far. Let me share maybe one more thing. What's interesting about existentialism is it's evolved over time. Early existentialism was seen as kind of a response to religiosity. And in that existentialism, postulates that our value and meaning come from our involvement in life, right? Whereas religiosity or religions say value and meaning come from somewhere else, right? So religion, spirituality say, like religions say, your meaning comes because you are created by God or because you are created by another entity. It comes from something beyond this world, right? Whereas existentialism early on said, no, you have meaning because you exist. And you have value because you exist, and not because you are you're created by a God or something of that nature, but just because you engage in life and you create meaning and value as you engage. It's not an inherent part of just our existence. And so that was seen as conflictual. In more recent years, there's been some really cool literature that tries to connect some of that together a little bit more. across religions. Because, and why I say cool is because there's kind of this tension between the two, which is never kind of a fun thing. And so there's a lot of arguing. You see a lot of early literature that was fighting religionists with existentialists. But in much more recent decades, there's been much more of a harmony or an understanding of that, which in reality is probably more fitting, is that there's some context or something that fits within the cohesive nature of theory, right? We don't have to argue and fight theory. We can find the cohesion and the connection between them. So kind of fun stuff there. So if you were studying existentialism and you're like, ooh, I'm a religious person, right? And you're like, I don't really like this, or this seems to be counter to maybe some of my personal beliefs or religious beliefs. I would say keep going, because there's more. And it's not necessarily the case that way. But I often find students wrestle with that early on who are religious. So thought I would mention that. Okay. Now you've had more time to think. Questions or things that you even came across in your slides or modules that you're like, oh, how does this work? Or what's that?
I have kind of a question about transference and countertransference and the ethical implications of those.
Right. Do you want to be specific in your question, or is your question, what is the ethical implications of transference and countertransference?
That is my question. I just
Okay.
worded it very weirdly.
Paige, can I bounce between us a little bit?
Yeah, absolutely.
Can you tell me what you know about transference, or what you understood about transference or countertransference? And it's totally fine if you say, I really don't understand them. That's why I'm asking the question.
It's going to sound very formulaic because these are my notes from the slides. I'll try and put it in my own words, I guess. So from my understanding is that the client sees the therapist or well, this just says the client reacts to the therapist as he did to an earlier significant other. So like they transfer their like views or their relationship with someone in the past to their therapist. And that probably impacts the relationship with the therapist, I'm assuming.
Huh? And then countertransference is what? What's the difference?
When a therapist reacts towards a client and it can like occlude their objectivity because it, and that's kind of the confusion, like with the countertransference is the therapist basically engaging in the transference like just on the opposite side, like you remind me of my mom, or like you're like a friend I had in college, and so then it like clouds your objectivity because you see someone different than you're talking to, kind of.
You're nailing it. You're doing a great job, Paige. That's awesome. Yeah, all the above. So transference, according to Freud, was good, right? The object of being a therapist or psychotherapist for Freud was, I'm going to be a blank slate. And so anybody who kind of does Freud won't have things in their office that clients could use or see. Like I even have a colleague who doesn't wear a ring. He's married, but doesn't wear a ring in session because he wants to be a blank slate so that people can just sort of experience transference. Transference gives us as clinicians insight to our clients, right? And to what they're doing, and to who they are, purpose, value, meaning. We still use this today. I get clients that come in and engage in like caretaking behavior with me, or clients who have been through like really rough marriages. They will then engage in punishing behavior with me. Clients who have had really rough childhood experiences, they test and push and act a certain way when I resemble their dad, or a sibling or some male figure in their life, it gives me, transference gives me as a clinician insight to them. And it's really, really helpful. And there's nothing unethical about that. And doesn't compromise me in any type of way. Okay. Countertransference. Now, let me shift a little bit and see if anybody's ever had this experience. Has anybody ever been in a relationship with somebody and it's not going, there's some challenges you're facing, and so you go to a friend and you ask the friend and you tell the friend, you share with the friend what's going on in your relationship, and the friend then gives you like all this instruction of what to do, or says something like, you're better than that, you deserve more than that, like you should dump them, and you don't need this in your life, and da 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 da, and they give you like all this advice about what to do. Anybody ever had that? Anybody ever? Okay. It's good. I imagine most people have experienced something like that. I would probably tell you that what the friend is experiencing is countertransference. And it's probably their response to their friend number one, who's seeking out help or wanting to share because their relationship is going through some things. They're not wanting necessarily just what to be told to do, but the friend has had some bad experience in the past with relationships. And so then they are taking that and they're putting it on their friend. And we can see this happen in clinical experiences. One of the most common forms of countertransference is if you as a clinician had ever experienced abuse, domestic violence or child abuse or something like that, and you get a client that then comes in that has experienced domestic violence or abuse. Our unresolved clinical side, our unresolved side of that is going to cause us to act in ways that are different than we might normally as a clinician. We might become overly directive and tell them what they should do, or we might become overly caretaking. And that form of countertransference are unresolved challenges that then present themselves in the context of this therapeutic relationship, cause us to do things that are not therapeutic. And so that's countertransference. And that's the unethical side of it. Now, every clinician experiences some form of countertransference. And so the ethical assumptions or guidelines or the instructions that we have are that you should go see a therapist. So go see another therapist, go talk to somebody else about it, go work through your own countertransference so that you don't put that on your clients. But unfortunately, there's a lot of clinicians that do. They don't recognize that, and they put stuff on their clients. So by and large, one of the best ways to protect ourselves against that is we've moved away from I'm the know-it-all and you are the client and I tell you everything to do. And by and large, our professions say you don't give advice. You don't tell people what to do. If they are thinking about getting a divorce or separating, we do not tell them. If they are in a domestic violence relationship, we do not tell them to leave a domestic violence relationship. We do not tell them to stay in it. We don't tell somebody to stay in a relationship or to leave a relationship. If you ever have a clinician or therapist who tells you that, then you should probably walk out the door. They are not abiding by really common ethical practices with what we do. Most of what we do clinically is providing people with a space to make decisions for themselves. Does that help, Paige? Does that answer your question?
Yes, that helps. I love a
Good.
good analogy. So your friend advice analogy like painted the perfect picture for me.
Well, it's perfect. It's some of Freudian's concepts, those Freudian concepts that live on to today, that are still so much a part of what we do and how we act and interact. That it's like, hey, we can't throw the baby out with the bathwater just because Freud got a bunch of stuff wrong and maybe was an entirely great person. There are some really interesting concepts that emerged from his early work that are still part of what we do today. And most clinicians sort of recognize that. And most citizens, patients don't recognize that that stuff still exists. So, great question. Other questions that others have as you've been going through the material? Okay, I counted down from 10 to 1 in my head, which is what I'm told to do on a Zoom platform. So I counted to 10 to 1 really slowly, and nobody had any questions. So that must mean really nobody has any questions. As you think more about this content and material as we move forward, feel free to ask questions at any time. What we're going to see, so let me preface some of the material coming your way, okay? You're going to get into, if you haven't gotten into existentialism yet, you're going to get into existentialism, which is super interesting. It conflicts with a lot of what our current postmodern culture really deals with. And so some of you will like it, some of you really hate it. It'll be interesting. And then you'll get into Gestalt with Fritz Perls. And you'll be asked to watch a video of Fritz Perls doing therapy with Gloria. And that will be a really interesting reflection that you get to do there. Then we're going to get into some person-centered with Carl Rogers. And that's probably the time where things are going to sort of click and you're going to feel like not just think like, oh, this is cool and this makes sense and I like this, but where things are going to click a little bit more in terms of like, oh, if I were to go to therapy, this is what I'd like, sort of idea. Because we get a dramatic shift in ideology in therapy. Up until now, we are still under, and with even through Carl Rogers, we are still under this umbrella where there is widely accepted scientific or universal truth. It's a modernist stance of, hey, everybody will experience something. Existentialism says everybody experiences anxiety. It is a human experience, right? And so treatment in a modernist approach says, okay, everybody experiences something, everybody has something that's centrally, okay, here are central concepts that we can help people do in order to find treatment and help. We'll even get into behavioralism, cognitive behavioralism, and you'll see the same sorts of things. Then we'll shift, but we'll talk about that when we get there. So just keep that in mind as you're now addressing the next literature. Think about what, in context of when the theory came out, knowing what you know about the history a bit now, as you're receiving these theories, be thoughtful about really what was the context for which they existed and why they existed. Because these individuals are not like necessarily crotchety old people. They're actually pretty revolutionary in terms of what they're trying to do mental health wise. So just some thoughts there. Anyway, we will end for today. I think we'll end 10 minutes early. Again, just a small reminder, next Tuesday we won't meet for live. I will post a video kind of walking you through some of these concepts. Feel free to reach out with any questions you may have, or you can save them for our next live or a subsequent live after that. So anyway, everybody have a happy new year and stay safe, spend time with loved ones, and enjoy some of the new year. And we'll see you next year. No, shouldn't say it that way. See you next week. Okay, take care, everyone.